la la la. Whew. Okay, perfect. I just wanted to check and make sure the microphone was working for this one, because for the past hour of the cancer one, it was just recording in the right side, and that's like literally now with my settings indicate, but whatever. Anyways, tuberculosis. Now, why are we going over tuberculosis? Well, simply because this one is a lot of times on NCLEX, and we are going to just review it again. Yeah, that's basically it, actually. That's literally the reason. Overview. Tuberculosis is caused by a microbe, and who is that microbe's name? It's Mycobacterium tuberculosis. Yes. I think somebody might have knocked at my door. Hold on. What the crap? Okay, so apparently it was the door gnomes back at it again. Anyways, transmitted through airborne route. Okay, what is airborne route? That means if you get coughed on, buddy, you might just got the tuberculosis. Now the thing with tuberculosis is it might be dormant for years. Okay, the question I have: is dormant TB contagious? No, it's not. Dormant TB is not contagious. It's just sitting there, waiting for the moment to strike. So active tuberculosis is transmittable. Latent tuberculosis, not transmittable. Dormant TB occurs when the bacteria are present but not active and do not cause symptoms. In this state, the bacteria is unable to spread to others. So if you don't have symptoms, such as a cough or sneeze, really, then you're not going to be spreading the tuberculosis around. It's only when you have active tuberculosis that it's transmissive. Pulmonary versus extrapulmonary or miliary. So pulmonary tuberculosis is just tuberculosis that's just in the lungs. And I think it's just in it's not good. Pulmonary tuberculosis is not like, oh boy, I love it. But the thing is, I would rather have pulmonary tuberculosis than extrapulmonary tuberculosis, which is where the tuberculosis affects other organs other than your lungs, including lymph nodes, bones and joints, as well as the lining of your lungs, GI tract, central nervous system, GI tract, skin. They have GU tract and GI tract, okay. So, pulmonary tuberculosis. Look at this happy man. I don't think there's a single thought in that head. But main signs and symptoms of pulmonary tuberculosis. You know what? I do want to know, how does TB work? It spreads through the air, okay. The bacteria enter the lungs and begin to multiply. In most cases, the body's immune system is able to control the infection and prevent TB disease from developing, known as latent TB infection. In some cases, the immune system is unable to control the infection, and then the TB disease develops. Okay. How does TB affect the lungs? It causes infection and inflammation. Well. So, not only does the infection or in the inflammation from your immune system affect your own breathing, because it's affecting the lungs, causing decrease in gas exchange because of an increase of inflammation, but also the bacteria multiply and form in cavities, holes in the lung tissue, which release bacteria into the airways, spreading the infection and causing coughing. This whole process causes scarring and fibrosis of the lung tissue, leading to restricted airflow overall, which even if you get over a TB infection, it can decrease lung function. Makes sense. So, main symptoms of pulmonary tuberculosis, you may see some generalized weakness and tiredness, weight loss, fever, loss of appetite from just the fact that you have a bacterial infection. In the lungs, you'll see coughing, what the crap? Coughing, pleurisy, which is a medical term, guys, is a sharp pain. It's pleurisy, not pleurisy. Ugh, okay, well, whatever. It's a sharp pain felt in the chest when breathing in. So on inspiration, you feel like a pain. You feel pain. Inspiratory chest pain, huh? Coughing up of sputum, which is material from the lungs, and or blood. It will start out clear, and then as the TB progresses to become more like intense, it may look bloody. And then, of course, shortness of breath. You may also experience night sweats. Risk factors for developing TB, of course, if you are immunocompromised, because usually your immune system would like want to or be able to kind of fight this off. But if it's not able to fight this off, then you have TB now. But also if you live in like close contact with a lot of people, so like if you are in a maybe lower economic state or status area, and you are in a big group of people, or you're around a lot of sick people all the time, nursing homes especially are going to be really big places that TB can be spread through, because everyone is close together, and they a lot of times are not really in the best health place. Poorly ventilated spaces such as prisons and refugee camps, just because everyone is tightly packed together, and if one person coughs, everybody's got it. And then outside of the country, if you traveled outside, sometimes you can get tuberculosis, because sometimes you can get into contact with somebody who has it. But in general, the poorly ventilated and small spaces, close contact with individuals that are infected, those are going to be the most likely ways that somebody will get TB. And of course, if you are immunocompromised. TB screening. So, TB screening. This is not a diagnosis, because screening is different than diagnosis, but screening is just to see if you have it. It's just to see if you have been exposed. How about that? If you've been exposed to TB, or if your body has had to it has come in contact with tuberculosis. And I don't mean if you walked by somebody and figured out they had tuberculosis. I mean your body actually got a little bit of it and had to either fight it off, or it's still chilling there. Meaning your body has made antibodies to it. Now, screening, there's questions that can be done if you ask questions about somebody's tuberculous, status. Have you been close to somebody who has tuberculosis? Have you had any of these signs and symptoms? Blah, blah, blah. But the most classic screening tool for tuberculosis is the MAN2 test, or PPD. What the crap does PPD stand for? That's not it. Probably peptide protein derivative skin tests. That's the one. So the point of these is that they take this needle and they stick it right under the skin. Not into the tissue, like right under the skin. And they inject like this protein derivative under your skin. And they're looking for some sort of reaction, okay? So, in general, the bigger it is, the bigger the induration is, the better somebody's immune system is working, and the more able they are, or it looks like, the less risk they have for having the tuberculosis, okay? So a positive finding is good. We like positive findings for a PPD test. A positive finding is... Hold on. Okay, I'm just kidding. I'm literally just kidding. What the crap is going on? A positive reaction indicates that the person has been infected with the TB bacteria, but does not necessarily mean that they have active PB. So a positive finding means that the area of induration, okay, is, positive findings that they have been infected with the TB thing. So smaller induration areas just indicate, I guess, like, hold on. Positive test, okay, induration of 5 millimeters or more in people with a low risk. Okay, so if there's any sort of bump, it's a positive PPD test, which means you have been in contact with TB before. Okay? Having a bigger area of induration, so like something like that, means that you have a low risk of TB. Okay? So if you have a low risk of TB, this is, okay, I think I figured it out. This is how it is. So if you have a low risk for having TB, okay, and you don't have any other risk factors, a positive test will be an induration of 15 millimeters or more, okay? If you have an induration and it's smaller than 15 millimeters, you're fine, okay? If you are a resident or an employee of a long-term care facility, an IV drug user, or a recent immigrant, so less than 5 years, and you have an induration of greater than 10 millimeters or greater, I guess we would say, then you have a positive TB finding, okay? Now the reason, so that's your situation, okay? Because essentially it's like you need more of it to be more of a risk, I guess, okay? So if you are a resident of a long-term care facility or a recent immigrant or use IV drugs and you have an induration of 10 millimeters, which would be about this size, then that's a positive TB test, essentially, a positive PPD test. Well, not necessarily that you're, have TB like raging in your system right now, but you have been infected with TB. And then if you are HIV positive, have had recent contact with somebody with active tuberculosis or immunocompromised, an induration of 5 millimeters, which is that big, will be positive for you. Okay? So even if you have a smaller induration area, as long as that smaller induration area is greater than 5 millimeters, it's still a positive test. So that is how PPD tests work. It's not like, oh, well, this person has this induration of whatever. So everybody who has that induration will, okay, let's say you're, part of a long-term care facility or something and you have a 15, what the frick? If you're in the general public and you have 16 millimeters, you're fine. 15 millimeters, we're worried. And then everything below 15 millimeters, no matter who you are, it's a positive finding, basically. Unless you are part of the general public. I'm trying to, you know what? I said that wrong again. If you're in the general public, it has to be over 15. If you're part of a resident or employee of a long-term care facility, it has to be over 10. If you're HIV positive, it has to be over 5. So somebody who's HIV positive can have any of these larger indurations, okay? It's that and larger for everybody in these different 3 categories. Ugh, okay. So for everybody, an induration of less than 5 millimeters is fine. That's negative. For everyone, an induration of less than 5 millimeters is a negative TB PPD skin test. But that takes a while. That takes a little bit. They have to come back to the thing to get re-looked at after 48 to 72 hours. And then if they don't do that, they have to throw away the entire test and do it again. And that nobody likes to do that. In fact, most people don't want to comply with anything, okay? So they came up with this blood test, which is a quantiferon gold TB screening test. And this is like, they take the blood and then they just run tests on it. They take these 4 tubes of blood here from you, and then they put them into a bunch of tests, and then after they do stuff, they do magic with the blood, we figure out if you have TB in your system or not. Of course, in order to be diagnosed with TB, the provider will also order a chest x-ray to look for active TB, okay? Because they want to figure out if it's latent or active. So to diagnose, they need a chest x-ray to see if there's active lesions. So like these areas right there, stuff that looks like that. The lungs are supposed to be clear, almost black. We don't like to see that. Acid fast smears can also be used. That's a sputum culture that will show for an active infection. Sorry, my phone just... Yeah. There you go. It shows an active infection can be used for evaluation of treatment compliance. So, okay. TB is interesting because somebody who has TB, they might just have to deal with it for a kind of a long time. But if they stick to their treatment regimen, okay, if they stick to their treatment regimen, then their contagiousness goes down. Okay, so like if somebody has TB and they get prescribed all the stuff we're going to talk about, they do it to the point where they're doing it every day. They are really a great patient, and they will take sputum cultures once every month. Okay, sometimes more than that, but they tend to take a sputum culture once every month. Okay, and if each of those sputum cultures for 3 months in a row are negative, that means that they're no longer contagious. Okay, that's good. That means that they can go out into their daily lives. They still have to continue their medication regimen because that bacteria is still there. It's just that they're not contagious anymore. It's a lot like that viral load thing for HIV. Okay, it's not like we're decreasing risk, but like here we're decreasing the number because they've been on their regimen, they've been getting their treatments, and so they are less likely to be spreading stuff around. And then, yep, sputum culture. And of course, if they do the sputum culture and they put it on a thing, they'll show that it grows Mycobacterium tuberculosis. So nursing diagnoses for somebody with this disease. Ineffective airway clearance is a big one because of all those nasty mucuses and all that. Ineffective breathing pattern. There is less effective lung tissue. Hyperthermia. Fever moment. And I am curious, hyperthermia, why? It's different than a fever. Why hyperthermia in TB? Oh, it is a persistent fever. Okay, I am kind of stupid. I said, oh yeah, it's a fever. Wait, is it a fever? Okay. Result of body's complex immune response to the mycobacterium's bacteria involving the release of mediators, blah, 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 blah. Pyrogens, of course. Fluid volume deficit, and I would say that has to do with insensible water loss as well as problems with airway. Why FVD in tuberculosis? FVD, fatty acid. What the frick? Okay, how about this? Gotta spell it out to you. Okay, hypovolemia can be due to diarrhea, vomiting, fever, increased water loss through sweating, poor oral fluid intake, as well as complications like tubercular meningitis and adrenal insufficiency. Okay, so the only thing we missed there are going to be diarrhea, vomiting, and then fever. We got the insensible water loss and the poor oral fluid intake. Imbalanced nutrition, less than body requirements. Well, probably not just because, they don't want to eat because their airway is all messed up, but maybe also because they are vomiting, and then maybe also because they are diarrheaing, and also maybe because every time they cough, that takes energy, and they're using up all their energy to fight off this infection. Rest for infection to spread, okay. And then activity intolerance, because they can't breathe very well. So complications. So what we talked about so far is pulmonary tuberculosis. We also kind of touched on miliary TB, which is when the TB spreads to everywhere else. Okay, we could even call it metabolizing, but it's called miliary TB. Okay, it spreads to multiple organs, and here's the thing, right? Bacteria, our body hates bacteria. Bacteria will just grow in our bodies and then just stay there. And they're like, I don't know why you don't want us around. And our body goes, it's because we hate you. And so our immune system will see this bacteria, freak out. And it's not like the bacteria is helping anything. The bacteria are, producing waste products and whatever, being nasty. And so, however, our body doesn't like it. So we're going to see an immune response in areas where we don't really want that, as well as decreased function in those areas due to the bacteria messing around. So in the brain, this will manifest as a really bad headache, neck stiffness, don't like that, drowsiness, and a decreased level of consciousness. Seizures, coma, death, people with meningitis. Meningitis. I definitely don't want anyone becoming brain dead. Thank you. So, yeah, not good. In our heart, this could show as pericarditis. That'll be inflammation of the sac that surrounds our heart, which could potentially cause cardiac tamponade. Dyspnea. Am I stupid? Anyway, dyspnea, which they're already experiencing. I don't know. Anyway, JVD, backup of fluid, just that gets stuck in the jugular veins. Pleuritic chest pain. I mean, they're already getting that, but yeah, it'll be in the, yeah. Pleuritic basically means, remember that, the pleurisy, the inspiration pain, yeah. Hypotension, and then cardiac tamponade. This can look like heart failure, and unfortunately, miliary TB can be life-threatening if it leads to shock. In fact, meningitis would also be really, really bad. Gosh. So we don't want this person to go into septic shock because the bacteria flows into the bloodstream and goes everywhere. TB treatment. Medications. Okay. We're at 11 of 16. We're doing really good. Okay, we're doing so good. We just have to keep on going. Four big ones. There are 4 big ones. Okay? These are the 4 big ones for TB. Information. Usually, if the patient knows once the patient is diagnosed with TB, they're going to get all 4 of these things. All 4 of them. Bam, 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 bam. Okay? Bam, 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 bam. That's 4. Okay, that was 4 big bams. All right. Now, they'll taper off the medications, like, as the treatment starts to work and compliance is fine, but it is so important that the patient adheres to the medication regimen. Okay, why? Why? Why do I care? Why does anyone care? Why can't I just not take my rifampin today? Okay, the reason is, okay, there's a lot of reasons, but the main 2 reasons. First of all, by the way, you are not helping your case. When the moment that you stop taking even one of those, you're potentially making it so that the bacteria has a backdoor and can continue to replicate, meaning that you will show as having active TB, which means you have to continue isolating in your home, not doing any, not breathing on a ton of people and blah, 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 okay? Nobody wants that. No, you don't want that, okay? First of all. Second of all, the last thing anybody needs right now, is, it is medication-resistant tuberculosis. And the best way that you can make your tuberculosis resistant to anything we try and do to stop it is by giving it little medication breaks, little medication vacations, so that the virus, the microbe can say, oh, okay, well, guys, we got a break, so now we can build up our own immune system and get immune to the medicine. Yay! So now that medicine will not work against the TB anymore because it's resistant to it because you give it too many breaks. You give it too many breaks to recover, and now it's gotten stronger. Anyways, some things that people will do to make sure that their patients are taking these, this is crazy. Direct observation therapy, or DOT. And this is where the patient and the health worker get on a freaking Zoom meeting, and the health worker, nurse, home health person, whatever, sits there and says, okay, show me your meds. And the patient reluctantly holds out their hand to the camera, and the healthcare worker is like, okay, now put them in your mouth, swallow them. Patient does it. Okay, open. Nothing. Okay, good job. I'll see you tomorrow. It's kind of crazy, but they did do that during COVID, which is kind of funny. But apparently it worked. Apparently it worked really well. Anyways, so let's talk a little bit about all of these. Actually, they have little pictures, so we'll talk about them as they come up. But overall, these are all going to be really hard on your liver, okay? These are all going to be hard on your liver. So the physician may really want to bring in this patient to follow up with like liver function tests, check on them. This patient needs to be educated on signs and symptoms of liver issues, any of that right upper quadrant pain, indigestion, jaundice, clotting issues, stuff like that. Fatigue is there, but they're already going to be fatigued because of TB. But if they are feeling undue fatigue, especially after the symptoms have kind of gone down as they've been adhering to the medication regimen, that's something to consider. Don't. So we have here, I wrote down a couple of those, but we'll go through them as we go through them. Okay. Look at these pretty little pictures. Isoniazid kills active growing mycobacteria outside the cell and inhibits the growth of dormant bacteria. Cool. Kills your bacteria. That's nice. Some patient education. And this is also your education, because you can't educate them if you don't know what you're talking about. Makes sense to me. I don't know what I'm talking about, and that's why I'm learning. So, anyway. Take on an empty stomach 1 hour before or 2 hours after food. Avoid antacids. Of course. If you're taking antacids, by the way, with your medication, what are you doing? Antacids' whole point is to help to make it so that your stomach is less good at absorbing things and breaking stuff down. So if you're taking antacids with any medication, your body is just not using the medication as effectively. Guys. Anyway, avoid antacids. Take a daily B vitamin, okay? Take a daily vitamin B. Why? Well, because isoniazid causes B6 deficiency, which can cause peripheral neuropathy. So, we want to prevent peripheral neuropathy by giving this person some extra B vitamins. Also, where can I find vitamin B in diet? Meat, poultry, fish, eggs, dairy, legumes, leafy greens, seeds, and fortified foods. Fortified foods just means that they put vitamin B in there. B6 specifically you'll find in chicken, poultry, fish, and some vegetables. Hey, things to know. Liver toxicity. Look at how they report dark urine, yellow appearance to skin of whites or eyes, and increased bruising or bleeding with all of these. Because they are all toxic to your liver, okay? Anyways. So yeah, that's isoniazid. Okay, rifampin kills slower growing organisms, which would be your TB. The drug for rifampin, this is important. Rifampin can turn your fluids orange. It's orange-red, which was the best color in the Crayola crayon set that I used to color. I was like, if I want red, I'm not using their crusty freaking red crayon. I'm using red-orange, by the way. Nobody cares. They're like, hello? Anyway, rifampin causes your fluids to be orange, although I looked it up and apparently it doesn't usually cause your sperm to be orange unless you like have a lot of it. I just was curious, okay? I was curious. Hold on. Now I have to ask, will vaginal discharge be red, orange, rifampin? Okay. This is normal. May cause urine, saliva, tears, and sweat to turn red-orange. So probably not anything else. So that's not good. Anyways, things to know. Soft contact lenses can be stained. That's really crazy. Hey guys, new eye contact color check. Anyways, reduces effectiveness of oral contraceptives. Find something else. Use a barrier protection. It's not that hard. Or talk to your, OBGYN about other stuff. And then liver toxic, of course. Rifampin also interacts with many drugs, so talk to your healthcare provider before about any changes to your medication list. Try not to take too many over-the-counter medications unless, you've verified with them. So yeah, pyrazanamide, okay? This kills organisms by hanging out inside them. So the pyrazanamide it's basically like you poison them, essentially. Pyrazanamide increases uric acid formation. So if you have gout, your gout might be worsened by taking the pyrazanamide because it increases your uric acid formation. So make sure you're drinking a lot of water. Nobody wants gout. You don't want your uric acid crystals to be growing in your freaking hands and feet, and they're very painful. So definitely drink lots of water, 3 liters a day, okay? And you don't want those issues to go to your kidney as well. Just drink lots of water. Pyrazanamide also causes photosensitivity, so, like cover up in the sunshine, wear sunscreen, you don't want that. And then liver failure. Ethambutol. Also, so this inhibits bacterial RNA synthesis, which is slow acting and needs to be used with other anti-TB drugs. In fact, all of them, at least if the provider wants to at the beginning. So with ethambutol, you want to avoid alcohol. By the way, just if you're taking any sort of medication, avoid alcohol. Or at least avoid drinking alcohol like right after you've taken the drug. Like that's just, don't do it. Report changes in vision, reduce color, blurred vision, reduce visual fields immediately, because this can cause optic neuritis and lead to blindness. When it comes to retinopathy or apparently optic neuritis, physicians will usually be like, stop the drug, no more, don't do it. So the drug is stopped, and once the drug is stopped, the problems will usually go away. Gout may worsen. Dang it! Gout may worsen with increased uric acid formation, so drink lots of water. And I think ethambutol, that one we just talked about, can also lead to peripheral neuropathy with this B6 deficiency. So with that ethambutol, you're going to be wanting to also, it's just, ethambutol is pretty intense. It's the recommended 4th drug, so they'll try it, and if it doesn't work out because it's not very, it's got a lot of side effects, they'll just stop it and move on to these other 3. Anyways, now, okay, they'll start with those 4 drugs first, but you notice that none of those are like your typical antibiotic, okay? If your TB becomes resistant to those ones, then they hit them with the streptomycin sulfate. This is only given if the other 4 treatments don't work. And it's used for multi-drug resistant TB. They're only going to use it for this because they want to make sure that they still, they don't want TB to start becoming resistant to this, because then what are we going to freaking do? We have to come up with something else. We're running out of tactics, okay? But this is what they'll use if your TB is resistant to everything. Although it can cause hearing problems, so check for tinnitus, check for decreased hearing ability. So this person will need to be monitored for hearing loss or hearing issues often. Just increase your water intake and monitor for reduced urine output, because they are renal toxic. They're hard on the loop of Henle. Let me just look up why, because we have time. Why is streptomycin sulfate hard on kidneys? Blah, 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 blah. Why is... Okay. Impair renal function, blah, 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 blah. Permanent vestibular damage, all evidence of wow, dang. Anyways, renal function. So, monitor for reduced urine output. Of course, hard on the loop of Henle, according to my professor. So, when it comes to protecting yourself, This person will be under strict airborne precautions. They will also, if there's a room available, they'll be in a negative pressure room. We all know that those don't always just grow on trees, so if they can be put in a negative pressure room, that would be better. If they can't, oh well. Now, somebody who's going in to care for this person will be wearing at least an N95 respirator, and maybe they'll be wearing a PAPR. Yup. Patient education, infection control. While they are still actively TBing, they need to stay in their home, not go into any public places while contagious. Now, they're not going to be isolated from their family because probably their family has been exposed to it too, but the family needs to be tested to see how bad it is with them. They need to so badly. 95% compliance is required for these people. That's higher than AIDS compliance. Holy crap. We need these people to be taking stuff every day, and that's where DOT comes in. Okay, did you take your medication? NBC. Yeah. It's kind of crazy, but it's really important that they take their medication. Not only so that they get better, but so that they don't get worse and that that the TB that they have becomes resistant to everything. That is not good. For this person, adequate nutrition is really important because if they adhere to their medication regimen, we've gotten pretty good at killing TB or getting rid of it. But they need to do as much as they can to help their own selves. So making sure they have a lot of vitamin A, B, E, K, all those fat-soluble vitamins in your diet, having a lot of good protein for rebuilding that tissue, and iron. That's good. Vitamin C will help enhance iron absorption. If you're taking iron supplements, your stool might look dark. It won't be tarry, it will be dark. If it's tarry, you have a GI bleed or something. Sputum specimen once every month. It's not contagious if they have a negative sputum specimen 3 months in a row, but they still will need to continue their medication treatment. Why? Oh, because they still have remnants of that stuff in their system. They might not be contagious anymore. They don't have to wear a mask in public. They can go outside, but they have to finish the course of their medication treatment so that the TB doesn't come back and so that it's not resistant to anything. And that's it. Yeehaw.